So sounds a bit boring, yet anyhow planning is obviously key to master your surgeries. If you fail to plan, you plan to fail. So planning an osteotomy, you can talk about hundreds of osteotomy shapes obviously. So this is about frontal plane deformity correction. I have no disclosures for this presentation. So the first thing obviously we need to take a look at is the long leg orientation. You need a long leg standing view, and usually we are advised that the position of the patella is the right thing to look at. Equally, I like to take a look at the proximal tip or the proximal position of the fibular head. If it's 1/3 covered, then it's actually an AP view. The patella, as we have seen and as we all know, is quite a mobile bone and therefore not the only reference. Equally, we need to take a look that the condyles are not square but pointing straight at us. So if we have this, then actually we know about the fact that we have an AP view. And then we need to take a look at the site of deformity itself. So we have taken a retrospective look in Hanover in 2014 on all our 340 osteotomies almost at that year, and we found that 20% of the deformities basically were originated in the femur, and sadly we only operated 1% of our patients at the femoral side. Maybe just because we were trained for the tibia. And having said that, it's quite obvious that we operated 19% of our patients at the wrong bone, which is a downside, and therefore this is a pledge for a proper analysis of the malalignment. Now, so to analyze your alignment, you need to be equipped with a systematic approach. And for this, you need to first identify your joint center. So the joint center of the proximal femur is simple. It's actually a sphere, and on an X-ray, the center of a sphere is the center of a circle. To find that is easy. Now for the knee itself, meaning the distal femur and the proximal tibia, it could be a bit more difficult, as there is multiple references. You could take the mantle of the skin, you could take the outer surrounding of the bone, you could take the roof of the notch or whatever. But if you look at these blue dots here, then you will see that regardless whatever systematic approach you choose, they are all lined up quite similarly at one spot. So the only thing, and the message here is actually that you just need to decide for something, and I personally, for the distal femur as joint center, have chosen the roof of the notch, and for the proximal tibia, the area in between the two spines. Now obviously we have a distal joint center of the tibia, which in my personal reference, and the same counts here, multiple options, my personal reference is the center of the talus. So now, as we have joint centers, one proximal and one distal joint center for the femur and for the tibia, we now need joint lines. And these joint lines actually are the ones around the knee that interest us, because we do osteotomies about the knee. So there is joint centers for the distal femur, which is the connection of the most distal points of the condyles, and then this joint line of the proximal tibia, which is the connection of the subcondylar sclerosis that we have seen in this video presentation and the live surgery from Dinshaw nicely, and that he has taken especially into account to remain the slope as it is anatomically. So these are now the joint lines and the joint centers. So the next thing we take a look at is axes. So there is anatomical axes, obviously, for the femur and the tibia. But as we do mechanical changes, we don't refer to these. So what is our interest is actually the mechanical axes. And there is one for the femur and one for the tibia. And the one for the femur goes from the proximal joint center to the distal joint center of the femur, and the one for the tibia goes from the proximal joint center to the distal joint center of the tibia. And this is why I divide those. It's quite simple. Just take your centers, connect them, and then you have your alignment. So now we have axes for the tibia, whereas here, based on the anatomical shape, anatomical and mechanical axes are the same. And for the femur, they differ. And this is why it's important. Okay? So we just take the anatomical, not the anatomical, but the mechanical axes. So then there is an overall axis. And this is the mechanical leg axis. And probably this leg axis, defined by Mikulic, is one of the reasons why we for so long have not really taken a look at where the overall malalignment really anatomically is. Because this axis is an axis that sums up femur and tibia. It just gives you an idea whether it's valgus or varus. And there is a slight medial axis deviation. Nonetheless, Mikulic, some 150 years ago, in his thesis paper, and here you have this thesis paper, described this mechanical lag axis as a Direktionslinie, which is a direction line. And he equally described and measured the MLDFA, and in contrast to Paley, the lateral proximal tibia angle. And this is the text quote now, sadly in German, so I translated this for you. And he said that the knee base is not perpendicular to the mechanical femoral axis, but forms an angle ranging from 89 to 85 degrees, which is actually the first ever quote, averaging at 87 of the MLDFA, and hypothesized that the tibial MPTA is actually, or the lateral proximal tibia angle, is the alternating angle to that. So this is the description of what Paley later on translated into this nomenclature, where he said that we have mechanical and anatomical axes, so therefore we have to refer to this with either a small m or an a, and obviously it's an m for us. Then we have medial or lateral, proximal or distal, femur or tibia. And so this is why, by definition, we talk about the mechanical lateral distal femur angle and the medial proximal tibia angle. And for the MPTA, there is no little m in front of the capital letters because for the tibia, technically seen, it's parallel. So this is the nomenclature. Now, why is it important to actually take a look at the individual approach and say, well, there is one femur and one tibia? It's quite simple, because you have this Mikulic line, which technically should pass the knee somewhere in the middle or close to it, and you have an inclined joint line, because you've seen that MPTA and MLDFA are 87 degrees, so you have an inclined joint line from lateral to the medial side. And the reason for this is because we are bipedical animals, and so when we walk, we move our foot to the center of gravity in order to find some balance. And when we do this, oblique joint line suddenly becomes horizontal. So it needs to be oblique in order to work under motion when we really put load on our knee joint. So that's the whole purpose of it. And we need to take a look at the joint line and the Mikulic line together, because you can correct either of those. Like here, when you have your car and you have a towing in or towing out of the tires, you can align this, and then you have a perfectly aligned Mikulic line. But still, you can have a negative or positive camber, which would probably lead to shear forces and wear. And you can translate this directly to the mechanical problem of the knee. Okay, so this is why we please take a look at both of them. And there is now recent evidence for this, actually, and it's funny that actually George Babbis, who did this great series of double-level osteotomies, and found when he retrospectively worked up his own patients, that the ones that actually failed amongst his cohort of patients, where 97% actually survived for 7 years, the ones that failed were the outliers out of an oblique joint line orientation. So we have evidence now that it is just correct to not overcorrect, because there you create shear forces, and the further you overcorrect and overdo it and change normal anatomy pattern, actually you create shear forces and hyperpressure at the spines, and this is what we must not do. So now how to plan if we have found out that actually there is a malalignment and we detected and analyzed the source of malalignment? Well, there is this planning method according Dugdale and Noyes, and obviously you can just draw a correction Mikulic line, a so-called virtual Mikulic line, and draw another connection line from the tibia, and the resulting angle would be the angle of correction. That is very simple, yet technically and geographically not really, geometrically not really correct. Because as a matter of fact, the hinge here is in the joint and not where the hinge really is. So Rolli Jacob and Mignazzi came up with a different planning, and they had to translate the angular correction to the hinge point. And it goes like that. You have the same long leg standing X-ray. You have your Mikulic line and your virtual Mikulic line. And that passes where you actually want to have your correction at the very end of the procedure. Then you actually have the hinge point. And the hinge point is where all the action happens, and that's why the hinge point is so important. Now, let's hope that this video runs. So, and I always explain it's best to actually become the hinge. Because when you change your perspective and you become the hinge, then you just have to rotate your head and look from the ankle joint perspective where you've just been and rotate your head to the position where you want to be at the end of the procedure. And this change of neck rotation that you perform is actually the sword angle for the correction. Now, as you're having this correction, which is here described as line A and line B, and the angular correction in between, you just have to translate this to the cortex, and there you can measure on a calibrated X-ray the height of the correction. So we call this the angle A. And the same goes for distal femoral osteotomy. Now, let's say this is a closed wedge correction here, but that's actually regardless of the shape of the correction. We have our Mikulicz line here, the virtual Mikulicz line, and once again, we define the hinge point. Now, for the distal femur, only the cut has changed. So traditionally, based on the fact that we use these blade plates, the horizontal cut was the one that we carried out for these corrections. Based on the work of Stahelin, we know that it's way better to cut out an isosceles triangle in order to have a cortical fit that supports initial strength and stability with no cortical offset, and that guarantees a higher stability. So we are looking for one point based on this hinge point that we define prior, which actually starts at the, as a perpendicular line to a tangent on the starting cortex. And around this perpendicular line, the osteotomy just dials in. So doing this here once again, you have your hinge point. Once again, doesn't start automatically, so I do it. So once again, you become the hinge. Let's go through it a bit quicker. And once you become the hinge, you can rotate your osteotomy around it. And once your proximal femoral center hits the virtual correction, the virtual Mikulicz line, actually you have found your angular correction. You translate this angular correction to the cortex, and there we go. So as a take-home mantra, you have to check for proper X-ray orientation. If your X-ray is wrongly oriented, you cannot plan on it. So what you have to do then is you send your patient back to the radiologic department and get a new X-ray. That's the only way to find out. You develop an analytic approach to plan those corrections. If you don't have an analytic approach, you will never find a way to repetitively do the same. And this is a very plannable thing. It's actually easy to plan, so this is why that is important. It's very important to analyze the malalignment prior to your planning, because if you have not analyzed where the source of malalignment is, you will not be able to plan the right surgery, or you plan the wrong surgery like we did in our 350 cases. And sadly for the patient, that is an issue. So analyze first and then plan. Focus on the hinge point. Become the hinge yourself. Look the whole and think the whole osteotomy from the hinge point. It's way easier to actually then circulate the whole angular correction around this hinge and translate the angle into metrics, and this is why we have calibrated X-rays. So this is just a short one for you here. If you're very interested in osteotomy, we have another course in April in Hyderabad, and then I want to thank you for your patience.